Welcome to Benefits Redefined, a series of conversations focused on rewriting the employer playbook. If you're an employer today, you're being pulled in a dozen directions at once. Rising healthcare costs, increasingly complex care decisions, growing employee expectations, and constant innovation. Too often, those forces are treated separately. Costs live in one conversation, care in another, culture somewhere else entirely. This podcast exists because those things don't actually operate in silos. I'm Richard Silberstein, and I work with a group of colleagues across the country who spend our time helping employers move beyond transactional benefits and towards strategies that actually work in the real world. Each episode features practitioners who are in the work every day, not theorists, not sales pitches, but people helping employers navigate what's next in employee benefits, healthcare risk, and enterprise strategy. Today's session is Clinical Oversight and Advocacy, how employers actually prevent million-dollar mistakes. We are going to discuss what's driving cost and causing double-digit rate increases for employers' health plans and how employers actually control it in real time. I am super excited for today's discussion with one of my colleagues, Julie Kueppers. Great to have you here, Julie.
Great to be here.
So let everybody know, who is Julie Kueppers and a little bit of what you do and what your team does.
Sure. So as Richard said, I'm Julie Kueppers, and I'm the VP of Clinical Consulting here at Alera Group. And just a little about my background. I'm a family nurse practitioner and practiced clinically for years in emergency medicine and primary care. And I'm also a health researcher, and I have a PhD in health science. Prior to coming to Alera Group, I was the director of chronic disease prevention at a local academic medical center, and in that role oversaw a lifestyle medicine clinic, employee wellness programs, and a portfolio of grants that were really focused on health promotion and disease prevention, particularly in vulnerable populations. So that was prior to joining Alera Group now almost 6 years ago. So I joined Alera Group in March 2020 when nothing else was happening in the world. And that was a great transition for me to learn more about the health payer side, the health delivery side. And since that time, I now lead a clinical team in analyzing healthcare data and identifying trends and cost drivers for our populations, and then working with our teams to develop strategies around how to mitigate some of those costs and hopefully improve population health.
Cool. And you do a great job, and your team does a great job. To help people understand, why is there a need for clinical oversight and an advocacy team in the first place? Because not everybody has access to the superstars that you all are and do for our clients.
Yeah, that's a great question. So I think when you're looking at healthcare claims data, sometimes what you get are reports, very long reports with a lot of data in them, or even just short reports that say more data in aggregate. But with our clinical team, we're really able to dive into that data, look at that claims level detail, that granular detail that helps provide that understanding and the detail needed to understand what is really driving cost on your plan. So as we talk about a couple examples here over the next hour or so, we'll see when we dive in that some of these questions really can't be answered by just looking at a claim in aggregate. You have to look at the treatment trajectory and the treatment regimens going on to know what's happening.
And we had a session with Jennifer on the pharmacy side, who you know very well. And I think she made a comment that a lot of people get these reports, have this data, kind of feel like it is what it is. There's nothing they can do. And I feel like that's the same on your side as you look at a lot of these reports, and as you think about helping employers understand that they do have control, they do have data, it's their data, and they need to figure out how to leverage it.
That's exactly it. I think employers have the ability to drive change in healthcare spend, and that starts with having access to claims data so that you can determine which conditions are having the largest impact on your plan. But the data alone is just not enough to change outcomes. It's really how you use the data, how you translate that data into actionable insights, and that's where the magic happens.
And you do create the magic.
I need a wand.
That's right. So let's talk about the Pareto principle. As I think it for people that are listening in, I think the CFOs and the HR folks that are listening, and they know this, for people that are not as close to it, 1% of people drive 25% of claims, right? I think it's 5% drive 50%,
Yep.
20% or 25% drive 75, 80%. help people understand what is going on with large claimants, or when you look at the data, we're talking about like huge amount of medical claims that for this very small population, right? And that is affecting everybody, but there's things that you can do to help manage that a little bit better. So talk about maybe the 1% causing the 25% or the 5%, what you see.
Sure. And we get asked that a lot, Richard. Our team gets asked, why do you focus so heavily on high-cost claimants? And I think the principles that you just discussed are exactly why. So if you're thinking about 5% of your population accounting for 50% of your costs, if you are a 1,000-life employer, we're talking about 50 people. So if we can really figure out what's happening with that subset of the population and start to develop our strategies around that subset, that will really make a remarkable difference in your plan spend. So looking at those top members on the plan, what our team really does is focuses in on those high cost claimants. So we like to understand what's happening with them in terms of treatment and diagnosis. And we also want to be able to know when those claims are happening in real time. So when we get the claims, we want to identify that as soon as possible. And then we can use all of that information to help explain that to our employers as to what's going on with the claimants. Use that again to help with stop loss negotiations, with budgeting and forecasting, and then, of course, with developing strategies to mitigate those costs going forward.
Right. And you said something that was on the back of my mind for people to know is that you don't have to wait till the renewal. You don't have to wait till you're meeting with the TPA or carrier. You all are getting file feeds, probably with data is it like 30 days old maybe?
Like about 4 to 6 weeks.
4 to 6 weeks. And so you could say, hey, this client, this company just had a large claim, and sort of you and your team are looking at that to say, was that properly paid or was that in the right location? I know we'll get into some examples, but for people to just understand what that process is as to, your sort of secret superpowers behind the scenes.
Sure. So as we were reviewing high cost claimants more on an annual or even biannual basis with our clients, we were doing exactly what you said, is we were realizing that they were having these treatments maybe for the past 6 months, maybe the last year, and that we really wanted the ability to intervene as soon as those treatments started, or at least see them. So we developed this system, this infrastructure within our data analytics platform that identifies high-cost claims every time we receive a data refresh. So for all of our clients, whenever a high-cost claim hits, our clinical team sees that every month. And these could be someone that started a specialty medication that month, or an infusion medication, or dialysis, something high cost. And then that alerts our clinicians to go in and review all of the claim lines for those high-cost claimants. And when we do that, we approach that analysis asking the same 4 questions every time. So we're always asking, does this treatment seem appropriate for that diagnosis? Does that cost seem appropriate for the treatment? Is there any opportunity to optimize care? And is the plan being administered properly? And if we find that the answer is no to any of those questions, that is when we start to advocate on behalf of our employers by contacting the vendors, holding them accountable, asking those questions about what is it we're paying for, why are we paying for this, really asking them data-informed questions with clinically supported rationale.
So that is a great segue into, let's get into some real-life examples of the magic that you help do for employers, where you're helping to be their advocate to work with the carrier, the TPA, and save them, in some cases, hundreds of thousands and millions of dollars. So let's just talk about a few examples for those listening in. So think about site of care shift. I saw an email you sent, I think it was a few weeks ago, where somebody was getting, I think, infusion in the hospital, and I think you called Quantum, who was their care navigator, right? And tell people a little bit about that story and what the result was.
Sure. So yes, that was a great story. This person was on an infusion drug for a chronic disease, and they came up in our alerts because the infusion drug was so expensive. And so when I dove into the claim line details for that person, they had actually been receiving it in an office setting for around $40,000 per infusion. It's given twice a year. But the previous 2 infusions were done in an outpatient hospital setting at double that cost. So I did reach out to their care navigator and just asked, what's going on? Why did they have to move from an office back to outpatient hospital? Was there a reason, for example, maybe they had a reaction to the medication or they needed a dosage alteration or something to that effect? But there was no clinical rationale. And when they reached out to the patient also didn't know why they had to be moved, and they actually would much prefer to go back to the office or even home if possible. So we were able to facilitate that with the care navigator. They called the provider and worked that out, got the order sent to be a home infusion. And now, in this case, the patient was thrilled because they got to receive the infusion at home. And from the plan standpoint, that now decreased the cost in half. So now the plan will end up saving about $90,000 every year since this is an ongoing medication. So that was a win-win.
Yep. And then I know you work closely with one of my colleagues, Gail, and I think you might have been working on something that was in some place in Ohio that deals with, let's just say, the airline industry where there was was it Zolgensma? I remember there was a drug that was like $2 million that got questioned. And were you involved in that one, or do you recall that one?
I recall that one. That was a colleague of mine that was involved in that one. And I believe that they were able to negotiate a single case agreement with that particular drug. And that's something that when you think about these infusion drugs, there's a whole spectrum of strategies that you can be employing. So I think it first starts with looking at the infusion. Is it appropriate? And when you deem that it is clinically appropriate and that cost is egregious, so oftentimes we're seeing that when it's in an outpatient hospital setting, then we need to start to think about what can we do? We, of course, want our members to get the treatment they need. But is there a way to deliver this medication so that it's safe for the member, but it's at a more reasonable cost for the plan? And so these strategies can include things like single case agreements, which was the case for that Zolgensma. It can also include things like changing site of service, which we've just talked about, or even procuring the medication from the PBM and having that delivered to the hospital for administration, which is called white bagging. That's a strategy as well. But all of those strategies really depend on the cost of the medications, which always comes down to looking at that data and figuring out, are we overpaying or is this around what we would consider reasonable? Let's
just talk about, sometimes things are not intentional, but let's just talk about fraud, waste, and abuse. So sometimes it's unintentional. Somebody's just going to get care somewhere. Nobody's questioning it. They think that the carrier approved it. And then ultimately, it's the employer that pays the bill, right? And then some cases, there's things where just because of the way the contract's written, like I remember yesterday we were talking the lesser of, right?
Right.
So give an example of the lesser of, and we had that case in New Jersey with Horizon with the $100 million lawsuit,
yes,
right, which triggered that. But help people understand, like when you look at the data, some of it is carrier, some of it's contractual, some of it's hospital. But let's just touch base on the lesser of language without getting too into the nerdy weeds of benefits speak.
Sure. So the lesser of language, so what that means is that in your contracts, there is a provision in there sometimes and sometimes not that will say that the plan will pay the lesser of the provider's billed charges or what the carrier has negotiated with the provider for those charges. That number is not always the same. And we have one case in particular we've been working on in which a member was receiving a particular infusion for Crohn's disease. And the outpatient hospital where they were receiving it was billing $28,000 for that infusion. But the negotiated rate the plan had with that provider was $50,000 per infusion. And so they were billing $50,000, the plan was paying the $50,000, and really no one was the wiser until that started to hit our alerts. And so as we were digging into that and realizing, why is our plan paying double what this provider is charging? Nowhere else would you do that. No other industry would you pay double what you're being charged. And so we called the carrier on that and talked to them. And sometimes it's a little hard to get answers right away, but we dug into the contract for that and looked at the provision, and this client did have lesser of language in place. So the client should have actually been paying the billed charge, not just the negotiated rate in this case. So we were able actually to recoup that money for the last year on every infusion. Now, since that time, the carrier has amended the contract to get rid of that language, which we're seeing often.
Right.
But looking for that and knowing that that is occurring is very important.
So when you think of centers of excellence, give somebody an example of, well, one is what is it and why would I want to go here for some transplant or, you give some examples of that or an example of that.
These centers of excellence are just that. They have excellent high quality care. They have reasonable costs in which they charge for this care, and employers can have agreements with these centers of excellence in which they can send patients to these particular centers to receive that care. So, for example, when you said transplant, sending allowing a patient to go to a center of excellence for a transplant is ensuring that they're getting that high quality care, but at some sort of reasonable cost that has been negotiated. I can tell you a case that we're working on right now. We're seeing that initially we were told it was a stem cell transplant. This was like a $3 million cost to the plan. And so our team started to ask questions. What can you send us some claim lines? What's going on with this? How $3 million is a huge outlier. And when they sent us the details, it actually was not a stem cell transplant, but a cellular therapy, a CAR T therapy. And it took place at a hospital system, an outpatient hospital system, and that was their charge to the network. And so because it was such an outlier, we asked them for further detail and asked them, do you have any sort of centers of excellence in place, any single case agreements, any national programs that would help, because this cost is so egregious. And as it turned out, they looked into it post-payment. They started to review that case in more detail. And they found out that, in fact, they did have a single case agreement in place with that facility already, but they had not processed the claim properly. So they needed to go rerun it, reprocess it, and that will end up saving that employer about $1.5 million in doing that. So that kind of thing is just it really asking the right questions, asking those clinically backed questions as this doesn't make sense to us. Why is this the cost it is? As opposed to just throwing questions to the carriers or a multitude of questions, really focusing in on those highest cost questions and asking them for rationale on those. But that was just an interesting one because it was not done at a center of excellence, and things like this can happen.
Well, and that gets back to looking at the 1% or the 5% that drive 50% of claims. And it isn't like you're looking at 1,000 employees, but you're looking at those 50. Let's for those that are CFOs and HR that are on self-funded plans, they have something called stop loss, which is sort of catastrophic coverage because they're like the insurance company. And a lot of times you are getting requests from the team, right, where some client got some big rate increase on stop loss or what's called a laser, where we're not going to get into technical jargon, but basically where it's not advantageous to the employer financially. Talk about what you see at renewal time, where what role you can play with a stop loss negotiation or maybe a success story from that standpoint.
Sure. So perfect timing. So we just completed stop loss negotiations for one of the large captives that I work with. And with that particular arrangement, that stop loss vendor sends us the claimants that they're most concerned about in terms of which claimants are going to impact our rates the most. So in this instance, we got sent 50 claimants that were the ones they were most concerned about. And that allows our clinical team then to review all of those claimants, although we have been all year because we review their high-cost claimants throughout the year, but to review all the claimants to, again, look to see what's going on with them in terms of diagnosis and treatment, forecast out what we think the forecasted cost will be over the next 12 months, really based on just clinical knowledge of treatment regimens and experience of seeing cost of claims. And then we meet with the stop loss vendor to talk those through, to talk about any discrepancies we are seeing in our projections versus their projections. And in this particular instance, they sent over 50 and I had disagreements with 25. So we talk about those 25. And in one instance, for example, they had projected a claimant was going to be $900,000. And this was a claimant with a particular cardiac disease that was on an expensive specialty medication. And what had happened is that the patient just started an additional specialty medication, and the stop loss vendor was factoring in both of those medications being taken simultaneously. But for this condition, you would just take one. You wouldn't take both together. So providing that clinical rationale to them, they were able to decrease their projection in half, realizing, okay, they won't be on both of these. Or we had someone with chronic leukemia projected to be $700,000 by stop loss, but that person with their particular form of leukemia would only be on the infusion medication that they were basing this projection on only for 6 months. And so they had just finished it that month. So clinically, they wouldn't stay on that medication going forward. So there's really no reason to factor that into the projection. So having those clinical discussions has been very helpful in reducing projections.
Well, for those listening in that work in this space, you can see why I love working with Julie and her team and knowing about her superpowers from that standpoint. So if somebody's listening to this and let's say they're just getting carrier reporting, TPA reporting, talk about getting access to your claim data. I mean, it's really your data and it depends on the size of the employer, depends on if it's a carrier TPA, but maybe just talk first about why it is important for people to understand that it is their data, and then two, that what expectation is to get your data.
Right. So as a self-insured employer, you own that data. So you should be able to get that data from your vendors, meaning your TPAs and PBMs, easily. You should be able to get that. And ideally, you would want to put that in a data platform so that you can see that data. So it's very important, especially if you've carved out your PBM, that you have your medical data and your PBM data, your pharmacy data, all in one spot. And the reason I say this is that sometimes what we'll see is, and this is an example that actually just happened, is that someone had received a particular medication and the plan had paid for it on the medical plan. This was an infusion medication. So they paid for it on the medical plan. We saw that come through at $36,000, and that's a reasonable cost for that infusion. But then we also saw it on the pharmacy plan for $50,000, same medication, same date of service. And so we were able then to go back to the PBM and say, hey, the plan already paid for that on the medical plan. Why are they paying for it through the PBM? And as it turned out, the PBM had shipped that medication to the office and the office had accepted it, but the plan ended up paying twice for it. So luckily, we were able to get that claim reversed in the medical plan, and the plan didn't end up paying twice for it. But if you do not have that level of claims detail and that level of oversight to know what's happening in your plan, this plan would have just paid the $90,000 instead of the $40,000 that it should have paid.
I think not the best, because it's kind of sad in a way, but when we bring on a new client and you ask for the historical data and then you realize that people have been paying hundreds or thousands or millions of dollars, right? And then when they get the renewal, they're now going to their employees and changing their benefits, co-pays, deductibles, because they can't absorb a 15% increase. And if somebody was just being an advocate for them like you and your team do, it's a huge asset to have from that standpoint. So thank you for being here today. Great being with you. And I look forward to revisiting with you in 2026 because things are changing so fast. And I just think that, employers, the reason we're having this podcast is because every week I see and I learn things from you and others, and how do we spread the word? So thanks a lot.
Thank you so much. It was great to talk with you.
Okay. Have a great day.